Kiran, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is HIV-TB co-infection, case finding, management and prevention of tuberculosis. And the speaker is Dr. S. Kumar. Dr. S. Kumar, sir, has completed his diploma in TB and respiratory diseases and MD in general medicine from MMC. He was associated with GHTM Chennai as RMO and nodal officer at the Nodal DR-TB Center. He is recognized as a master trainer for NACO and TENSAX as well as PMDT services. He is the co-author for many papers on HIV-TB, and his field of interest includes care and support for HIV and TB patients. We welcome you, sir, for today's session and request you to start the session.
Good afternoon, one and all. Thank you very much for giving me this excellent opportunity to be in connect with our RDLS colleagues. And once again, I thank iTech and the team for giving me, Swet and others for giving this excellent opportunity. Can we have the first slide, please? So actually, it is a revisit for all of us being, this is based on the NACO guidelines, which have been 2021, it has been revised. So this is been based on the NACO guidelines. We have prepared these slides. Actually, the capacity building is one thing, which is the hallmark of our NACO and NTEP, where capacity building has allowed us to achieve great heights because of the knowledge dissemination down to the grassroots level. So on this, iTech has been one of our collaborators who have been way back from 2004, they have been involved in capacity building. So today, the 1 hour session, we are going to see the introduction to HIV-TB co-infection, some historical background. You know, this TB was way back in 1872, Robert Koch announced to the world about mycobacterial tuberculosis. More than 125 years have passed. Still, we are not able to eradicate the tuberculosis bacilli. Whereas this HIV is around 40 years old, 1981, it was found out in 83. They announced to the world about this HIV virus 1 and 2. So 87, the first drug came, Zidovudin, and 1995, a potent 3-drug regimen came into vogue. And in 2004, you know, even resource limited settings, we have started free ART for everyone. And that's drastically brought down the incidence rate. Now it is in 2020 figures, 0.2. Previously, during the peak of the epidemic, it was more than 1. Many of 6 of the states, it was more than 1 high prevalence states. Now it is only 0.2. So that is the success of the ART and the control of the HIV. But still, the HIV and TB is a very deadly combination. So that's why in 1993-94, WHO announced the global emergency on HIV and TB. So then from then we have been moving forward. Then we are going to see the general principles of management of HIV-TB co-infected patients. What is that? When to start and when to how to monitor everything, and the management of active TB disease in PLH, how to manage, how to follow up the patients. Then the adverse effects and drug interactions, because the anti-TB drugs which are commonly used in the drug sensitive. What is the adverse drug? The ADR is very, very important. You all know if you manage the ADR successfully, the adherence will be more. The patient's adherence will be more, and it will be successfully they can complete the treatment. So the finding out the ADRs and managing the ADRs, adverse drug reactions, is very, very important in any program. So the ART regimens, what are there, how to modify the regimen with TB co-infection, and finally on children living with HIV, a few points on the tuberculosis infected CLHIV. Next slide. So the second thing is that this is the 2.8 is the management NACO guidelines, that the chapter is there. We are going to our sessions based on that. Next slide. So we all know PLHIV are 18 times more likely to develop active TB disease than people without 1 minute. Okay. So TB accelerates HIV disease progression. HIV paves the way for clinical TB. So this is a vicious circle. So the next slide will show you how it is going to happen, the pathogenesis. So then a massive number of 71,000 incident TB patients among HIV in 2019 before the COVID era. Next slide. So how this HIV-TB interaction, how it happens in the human host. So suppose you see a HIV patient gets a TB infection. So what has happened? See on the left side of the screen, worsening immunosuppression in PL-HIV. So that will go on, bring down the decreased interferon gamma and Th1 lymphocytes. So what is the response of the Th1 lymphocytes come down? That is the cell-mediated immunity. So that will be brought down by the TB infection. So what will happen? The Mycobacterium tuberculosis clinical disease, the latent TB becomes active TB like that. So what will happen in that? It activates some macrophage cytokine production. That is the inflammatory, pro-inflammatory markers like interleukin-1, interleukin-6, and tumor necrosis factor. All this, and along with that, if the core receptors are activated, like the CCR5, CCXR4, these are activated. So that will increase the viral replication, more entry of the virus into the CD4 cells. And so this is a vicious circle. So what has happened? Then the viral replication increases and then the full-blown AIDS occurs. When the full-blown AIDS occurs, then there'll be more clinical TB patients. So it's a vicious circle, and we have to bring down put a halt to the vicious circle in the form of early detection of TB in HIV and early detection of and starting the patient on ART very early so that the immune restoration occurs. So you all know the TB patients, many studies have shown that around 7% of them will be HIV positive. Many of our studies have shown that. Next slide. So the general principles for management of HIV-TB patients. Next slide. So what are the general principles in the management? So intensified case finding, that is using the 4S complex, fast tracking and referral of symptomatic patients for rapid molecular diagnosis. So these are all always known to our ART colleagues, the 4S complex, symptom complex. So it's a very meta-analysis have shown that it is very specific, and easily the 4 symptoms are almost have a more than 80% specificity to tracking the HIV-TB infection. So prompt and effective treatment of active TB patients in accordance with the NTP guidelines. So what are the new guidelines? What are the new things that have come? You'll be seeing. And early initiation and continuation ART in HIV with TB co-infection. And cotrimoxazole preventive therapy, CPT is very important. Then we have the TPT also, TB preventive therapy in the form of INH for 6 months, which have come into full implementation nowadays. Next slide. So what is, so this is a diagnostic or a flow chart showing how to go about. So the adults, adolescents, we have the current cough, fever, weight loss, night sweats. In children, the weight loss is replaced by poor weight gain or reported weight loss. And there is an important thing, the history of contact with the TB case. So children, contact history, reverse trace tracking is very important in children. So then if there is a 4S or positive, then we have to investigate for TB and other diseases. Now you know we have this important molecular diagnostic tools for tuberculosis in the form of Gene Expert and TrueNat and as well as LPA. So these are the tools. So previously we had only the Zeal-Nielsen, and the Zeal-Nielsen, the specific sensitivity is 54%, whereas it's more than 80%, and the turnaround time take more number of minutes to see in the Zeal-Nielsen, whereas in a Gene Expert, more number of cases can be seen. And also we have the fluorescent microscope. These are the new things which have come up. And whereas in the other side, we have this culture and all. Culture and liquid culture takes more time. Turnaround time is more than 15 days for liquid culture and 6 weeks for solid culture. So we are now have a good armamentarium of molecular tests. So suppose the first symptom is there, investigate for TB and other diseases. TB, once TB for treat for TB. So we are going to assess them. If not a TB patient, then we are going to consider for IPT. Give appropriate treatment and consider IPT if no contraindication. So access for contraindication IPT, no give IPT. So children, same thing. Defer IPT if there is a, we are not going to we are not in a position to rule out an active TB, then defer IPT, that is INH preventive therapy. Next slide. So, chat box, it has come. What is the difference between CBNAT and TrueNAT? So actually, this cartridge-based nucleic acid amplification test, this is a CBNAT, cartridge-based, is that there are probes are there. These probes will detect first the proteins of the mycobacterium, then these probes, other two probes will detect the RIF-resistant genes of the same specimen. So this is the CBNAT, gene expert, otherwise called, because it's the expert, the company's name. So what is TrueNAT? Is almost TrueNAT is same thing. Only thing, it's indigenous preparation made by our Indian people. Where CBNAT, you can put 4 samples or 8 samples or 16 samples, whereas in TrueNAT only 1 sample. It is battery operated. Less number, 5.5 ml of specimen is enough, and it can be used in remote areas, and that is the difference between CBNAT and TrueNAT. In CBNAT also, UltraNAT has come. CBNAT can detect around 100 bacilli in a given specimen, whereas the same gene needs 10,000 bacilli to become positive, whereas CBNAT only 116 or something, where in a TrueNAT even 16 bacilli are there, it will show. So that is a CBNAT is ultra, and TrueNAT also same. So TrueNAT is indigenous CBNAT used in remote places. So coming back to our TB diagnosis recommended approach, 4S symptom on screening, undergo NAT test. So the NAT, you can know the CBNAT or the TrueNAT. What is that? What are the specimens you can go do the test? Is that sputum is the pulmonary tuberculosis sputum, or crushed lymph node, or in a pleural fluid, the yield will be less, ascitic fluid, and also in a CSF, we can do the CBNAT. Once it is contaminated with blood, the sample is inappropriate for our use. So we have to keep in mind. So make use of the NAT for wherever CBNAT or TrueNAT for the specimen, make use. So the RIF resistance is seen within 2 hours, you get the results. So RIF resistance seen, we are going to be, it's a drug resistant TB. The algorithm is different. RIF sensitive TB means one thing is very, very important, we should keep in mind. What is that? This NAT test only find about the sensitivity of rifampicin. It doesn't show about the INH. So once RIF sensitive means you should not be happy. We have to send a sample for first line LPA. The first line LPA, we have to send a sample. Why? Because if there is INH isolated resistance is there, we are going to replace the drug sensitive TB regimen. You replace the INH with the quinolone, levofloxacin. Same 6 to 9 months, no intensive phase, no continuation phase, all drugs 6 to 9 months in the INH mono resistance. So this is a very important thing. Up front itself, you should know. RIF sensitive means CBNAT should not be happy. You start the treatment and send for first line LPA. So NAT negative, or there is no inappropriate, TB is diagnosed. Suppose negative NAT also doesn't rule out TB. If the physician feels that the X-ray shows TB or some other, the HP shows TB, or the radiological findings are suggestive. Suppose the patient is having a very low CD4 count, you do ultrasound, there is para-aortic periphoral lymph nodes, then most probably the common things are common, it could be a disseminated TB. Then that case, you are a clinically diagnosed TB, you are going to start them on ATT. Then if the TB is ruled out, then you can evaluate for other alternate diagnosis with the higher center. So this is regarding the recommended approach to TB diagnosis in HIV. Next slide. So what is that classification of TB? For completion's sake, any guidelines will have a completion, definitions are there. So microbiological confirmation, that is the gold standard. So microbiologically confirmed TB means there is a specimen is positive for AFB, or positive on a NAT specimen, or a culture, liquid culture is positive for MTB, and all the quality assured rapid diagnostic molecular test like a NAT or TrueNAT. This is microbiologically confirmed case. Then comes the clinically diagnosed TB case. So clinically diagnosed TB case is there. It is not confirmed microbiologically but by a clinician based on X-ray, histopathology, or clinical science of the decision to treat TB full course of anti-TB treatment. Then comes the anatomical site of the disease. Pulmonary TB, any microbially confirmed clinically diagnosed TB patient. So extrapulmonary TB, any microbially confirmed clinically diagnosed case of TB involving lung parenchyma. So miliary TB is also classified as pulmonary TB because it's there in the lung, even though it is a hematogenous spread. Then the extrapulmonary TB, anything other than the lung, pleura, lymph nodes, intestine, genitourinary tract, all these are extrapulmonary TB. Next slide. History of previous treatment. A TB patient was never had treatment for TB or has taken anti-TB drugs for less than 1 month. So this is very, very important history of treatment for a new case or a previously treated case. So that's important. So recurrent case is one where TB is declared as successfully treated, cured, and is subsequently found to be microbiologically confirmed TB. So that's a recurrent case. History of previous treatment. So already patient failed treatment after last follow-up. So more than 1 month. Now they say 2 months. So those who are previously treated where records are not available or classified into any situation. Then comes the drug resistant. So drug resistant could be a monoresistant or polyresistant or multi-drug resistant or extensively drug resistant. Next slide. So sensitive TB is the one where isolated TB is susceptible to all the first-line drugs, rifampicin, INH, paracetamol, ethambutol. Drug resistant TB is defined as TB disease where the bacillus is resistant to one or more anti-TB drugs. So this is an important classification for management of a TB patient. Next slide. So what is that? Regimens are there? So there are now only one regimen, that is no retreatment also or a relapse case also. We have only a 6 months regimen where 2 months of intensive phase followed by 4 months of continuation phase. So the paracetamol will be stopped after the intensive phase. But there is a provision for extending the continuation phase by another 3 months if there is a residual lesion. In a case of bone TB or other extrapulmonary TB, we can extend the CP by another 3 months. So why we are giving only 2 months? We are not extending the first intensive phases because already we know the gene expert, we know that the sensitive TB. So we don't extend the IP by 3 months because already we have the record of our drug sensitivity pattern. So only 2 months of intensive phase followed by 4 to 7 months of continuation phase. So these are the standard regimen. So it's a fixed dose combination under NTP so that selectively the patient cannot avoid some drugs. So this is the intensive and CP. Next slide. So this has been all standardized. So we have the weight bands 25 to 30. So down the line, grassroots level workers can easily dispense the drugs because it is fixed at 4 FDC. All the 4 drugs can be given in the weight band, 2 tablets, 3 tablets, 4, 5, 6 like that. They have accurately dosed it. So loose TB drugs can be used for substitutions in case of adverse drug reactions or drug to drug. So slowly the streptomycin, other injectables are being phased out of the program on the NTP. So weight band is increases, then the patient more than 5 kg crosses to the next weight band during the follow-up. Okay, next slide. So clinical follow-up. So what is that? Every month the patient should be followed up for clinical symptoms, increase in weight and control of comorbid conditions and any adverse drug reaction. Very, very important. Also any iris. Sometimes the node can increase in size and it should be noted and the patient reassured on that. So that is very, very important. Lab follow-up is the sputum microscopy is done at the end of 2 months. That should not be repeated because dead bacilli can show a false positive results. So sputum smear at the end of treatment. So what is that follow-up also? 2 years, usually 24 months because the relapses usually occur within 2 years. So there will be 6, 12, 18 and 24 months follow-up of the TB patients. Next slide. So adverse reactions. Next slide. So this is very, very important. Drug interactions. So already, next slide. HIV and TB, both are, see the HIV, we have to take the drugs lifelong, ART. Whereas TB could be 9 to 11 months in a shorter MDR or 7 months, 4 to 6 months in a drug sensitive TB, or could be a long oral, 20 months, bedaquiline, long oral regimen in a MDR TB. So like that, there's a prolonged days. And so there could be drug effects. So, INH rifampicin, pyrrolidine. These the four drugs have been almost 80 years. They have been in the mainstay. No other new drug has come into program. So INH carefully, we have to see mainly because hepatitis can come, peripheral neuropathy, psychosis can come. Rifampicin, important thing is that it can cause hemolytic anemia, acute renal, that is the renal tubular necrosis can come. These are very rare. Usually they can cause nausea, vomiting, other things, and purpura, thrombocytopenia can come. So this is very, very important. Rifampicin. Then pyrazinamide, arthralgia and jaundice. Then cutaneous reactions can come. Stephen Johnson, we have seen in some of the HIV patients with pyrazinamide. So ethambutol, important thing is that retrobulbar neuritis. So you have to be very, very important. Arthralgia can also come. So you have to be always be alert under routine ophthal examination in MDR-TB. You have to take a baseline ophthal. After that, some 2 months later, you can do a ophthal examination to rule out a retrobulbar neuritis. So very, very important. Ethambutol. Remember always retrobulbar neuritis. Next slide. So what are the other things we should know? Next slide. So what are the symptoms such upper abdominal pain? So all anti-tubercular drugs can cause epigastric tenderness, nausea, vomiting. So you have to go by that, mainly pyrazinamide. So what is that? Sometimes they can ask them to take it at bedtime after food. Like that you can see the bioavailability is not much altered after if the drugs are taken at bedtime. So you can ask them to take at bedtime and sleep off the symptoms. So that can be itching and rashes. If it is a minor rash, you can just give antihistamines and observe. Suppose it goes into the mucous membranes or genital region, it could be impending toxic epidermal necrosis, Stephen Johnson. So then you have to be very careful. You have to stop all the drugs and send the patient to higher center for a judicious recheck. So what is it here? Important thing is that they're challenging the drug. So I think the pharmacovigilance, we all know, we have been all taught about the pharmacovigilance. So any drug causing any problem, you have to report to the pharmacovigilance in a fixed format so that you can accumulate more evidence on the drugs usage and effects and side effects and how to benefits and risks. So that is important thing. Next slide. So important thing is that the rifampicin is a very potent activator of a drug metabolizing enzymes like P450. So rifampicin is a culprit. So anything rifampicin will not be there. Only rifampicin can have a potential thing with the NNRTAs to nevirapine and PIs. So their therapeutic level comes down. So we have to be very careful. So we have to do not use it, PIs and nevirapine. So we have to use a rifabutin instead. So rifabutin can cause anterior uveitis. We have seen patients, 2-3 patients with anterior uveitis. So we have to be very careful with the rifabutin. Next slide. So anti-TB drugs are different anti-drugs used. So NRT usually we have that's all old regimens. Everything has been phased out. Stavin have been phased out. So efavirenz, remember, can be used with the routine ART. Nothing will happen. So efavirenz drug level doesn't come down. So nevirapine we should not use. So nevirapine is not being used in the program routinely now. So PAs, you have to use rifabutin instead of rifampicin. So dolutegravir, you have to double the dose of dolutegravir. 50 milligram usually given in TLD. You have to increase the dose to morning 50 milligram. So that is important. If rifabutin is used, dolutegravir need not be scaled down. So raltegravir used per the guidelines. Sometimes rifampicin interacts alter, so double dose we have to give, but usually rifabutin is used in place of rifampicin. So these are the common drug-to-drug interactions of different ART and ARB. Next slide. So when to stop the drug? So commonly usually you see jaundice. So when the raised liver enzymes occur, clinical jaundice allows raised liver enzymes more than 5 times, like 40 baseline, it can be 100, 200. So once this SGOT-PT increases more than the 5 times or 3 times, with the jaundice, you have to stop all the drugs. And usually it is only a idiosyncratic reaction, like some allergic reaction. Usually, once you restart, usually they tolerate well. After 2 to 3 weeks, you can restart. Suppose the patient is very symptomatic, with extensive TB disease, you can give them quinolone, levofloxacin, and ethambutol, least hepatotoxic drugs that can be given. Suppose loose drugs, you can even SM judiciously can be used in less than 50 years of age. SEO usually used to tell juniors, SEO. Then we can restart all the drugs at judicious use. So what is that important thing is that you should know when not to rechallenge. Suppose a patient has purpura, platelets coming down because of rifampicin, never ever rechallenge. You have to go for a non-FDE 1 year regimen. Suppose a patient has a Steven Johnson-like syndrome, never ever rechallenge with pyrazinamide. You have to go for a other regimen. So rechallenging is life-threatening if you have to be very careful. Only some other things you can rechallenge. And that whatever things you should not rechallenge are any acute tubular necrosis or renal failure of rifampicin, purpura, thrombocytopenic purpura, and then suppose you are restarting with after jaundice. Again, restarting, again the patient develops a jaundice, means you have to stop it and no ever rechallenge. Then go for a non-FD regimen. So these are the common things of drug-induced hepatitis and other things. And clinical concern, protracted vomiting, mental signs of bleeding, acute liver failure, immediately discontinue the anti-TB. Fulminant hepatitis, that called fulminant hepatitis. Previously, during the nevirapine period, we had seen after starting the ART, fulminant hepatitis occurring, SGOTPT 8000, and we have lost patients. So that's why the nevirapine had been phased out. Next slide. Management of jaundice and other features. So it could be already I've told you how to, when the baseline it returns to baseline, we can restart judiciously. Next slide. So how to go about the dosage and renal impairment. So this is usually you have to calculate based on the Cockcraft-Gort formula, and you can moderate, severe creatinine clearance calculation, and you can do that. You can have it a ready reckoner on the table and follow that. Next slide. So what is that algorithms or reintroduction? So same, it's all I have already told you. Ocular toxicity, never ever rechallenge. Ethambutol should not be rechallenged again. So why now ocular tox is important in that? Previously, we were not giving the ethambutol in the continuation phase. We were giving only INH and rifampicin. But that led to a lot of relapses. Operational research has shown that that regimen was inferior. A lot of relapses occurred. So that's why we are giving 3 drugs in the continuation phase. So when ethambutol was given for a prolonged period here, almost 6 months to 9 months. Also in the shorter MDR also it's being given for a prolonged period. We have to be very careful and talk about the ocular toxicity. And the second line drug, linezolid also is an important culprit for ocular toxicity. Then non-serious ADR, just a reassurance. If no mucus involvement is there, then slowly we can introduce one by one with the antihistamines and other things. So what I already told, aplastic anemia, INH and linezolid, so be careful. So all these are already we have been discussed it. And now autotoxicity is less because the aminoglycosides are being slowly phased out of the drug sensitive as well as drug resistant TB regimens. Next slide. So all these how to go about stepwise. So it depends on the senior physicians, clinicians. They go about in or simple different ways. Next slide. So what are the outcomes of treatment? Cured patient, microbially confirmed at the treatment who were smear or culture at the end of the treatment with good clinical remission. Treatment completed. Some of them complete the treatment because test was not done or result not really clinically diagnosed patient who has received a full course of treatment with no positive smear at the end of treatment, no records, then they're called treatment completed. Success means treatment patients cured or treatment completed or accounted in treatment success, but it's not an indicator, not an outcome. It's only an indicator. Next slide. So these are some of the definitions we should know. Then types of treatment. Then what are the other things? Drug sensitive TB outcome. Failure. Once was not converted. So specimen is still positive means the treatment failure. Then failure to respond. A pediatric TB to have conversion state of 12 weeks of complaint intervention deemed to have failed response, alternative diagnosed by non-response have been ruled out. So in a TB pediatric patient, negative status or fails to respond clinically or deteriorates, then it's called failure to respond. Lost to follow more than 1 month, then nowadays I think some people say more than 2 months. So not evaluated under transfer out. So the patient is transferred to other zone, it's not is come under not evaluated. So these are the definitions, very, very important in the program for us to have a complete monitoring and evaluation and operational research. Patient who dies of any cause during the anti-TB treatment. Next slide. So HIV-TB co-infected patients, ART should be started as soon as possible within 2 weeks. So initiating TB. So TB treatment is the first priority. You start the treatment regardless of the CD4 count. Then you start the ART. So appropriate ART regimen. So among PLHV-TB meningitis, ART should be delayed for at least 4 weeks. Why? Because in a CNS TB, if you are going to start ART immediately, because CNS TB only advanced immunosuppression, and it is a disseminated TB. When you start ART, there will be immune reconstitution and there will be adhesions and life-threatening complications can occur. So that's why you have to start after 4 weeks after treatment TB meningitis initiated. Corticosteroid should be considered as an adjuvant for TB meningitis to prevent adhesions. Next slide. So these are some special points. Then with HIV-TB co-infection, so these are the standard guidelines what being given. More than 30 kg, TDA, TLD, tenofovir, lamivudine, dolutegravir. Then we have to add a dolutegravir extra. So that is the management of HIV-TB. With the body weight less than 30 kg, it is abacavir instead of TDF. Along with that, same thing, abacavir is there. So then high liver enzymes are there. So there also abacavir, lamivudine, and DTG as per creatinine clearance. So women of childbearing age, tenofovir, lamivudine, efavirenz, if they have got to explain to them about the neural tube defect of the dolutegravir, other things, and they are TLE is okay, and then just like that started on the anti-TB regimen. So HIV-2 and prior treatment with NNRT exposure means tenofovir, lamivudine plus we have a lopinavir ritonavir. That is an important change you have to find. You have to keep in mind. HIV-2 and HIV-1 and 2 prior exposed to NNRT during delivery. So this is an important one. So they have been given a PA. And when that PA is coming, the drug sensitive TB, rifampicin should be replaced with rifabutine in the regimen. So this is an important point you should know. Next slide. So coming back to the ART with the same these regimens, is that some of the patients rarely can be on zidovudine or tenofovir plus abacavir and 3-TC, dolutegravir. Dolutegravir has to be given additionally. That is important. Then if it is efavirenz, no change in the required ART. ATT, same thing. Okay, next slide. So TB co-infection, further regimens have been discussed here. PI plus dolutegravir, all these are permutations and combinations which will be occurring in your day-to-day practice that you can discuss amongst yourselves and start the treatment accordingly. So only thing you have to keep in mind is the HIV-TB co-infection. What are the drug-to-drug interaction so that the bioavailability of the drugs don't come down, so that the treatment failure occurs. That will lead to a lot of problems. That is the one thing you have to keep in mind. Next slide. Treatment of drug-resistant TB. So that's an important thing now because of the good, next slide, because of the good molecular tests available, we are able to diagnose the drug-resistant TB very fast, very quickly in patients. Next slide, please. So what is the classification? So drug-resistant TB, monoresistant TB, a patient whose biological specimen is to one first-line drug. So commonly we come across next, that is the INH-resistant TB, HR-TB. So PB patient whose biological specimen is resistant to INH and rifampicin system is controlled. So this is a INH-resistant TB. So it requires a bit different regimen. We have to substitute INH with quinolone. So that is the thing, and no intensive continuation phase. 6 to 9 months of continuous treatment for this INH mono cases. Then RIF-resistant TB is practically MDR TB. In program, we consider RIF-resistant TB alone to be also a MDR TB. So this is using, we are deducting using a phenotypic or genotypic. You know, genotypic is CBNAT, TrueNAT or LPA, and phenotype is all these grown through liquid culture or solid culture. You are growing the organism and seeing the bug. So that is the phenotype. It takes more time, minimum 2 weeks in a liquid culture. So with or resistant to other TB drugs is a rifampicin. So we have to go about that. Polydrug is one where there is more than one first line, not INH and RIF. Suppose you have as facilities available. Suppose a patient is resistant to EMB. Suppose a patient is resistant to pyrazinamide. Then it's called a polydrug resistant. Next slide. So multi-drug, already I told you, INH and RIF resistance means multi-drug resistance. So pre-extensively drug-resistant TB means RIF and INH plus a quinolone, because quinolone like moxifloxacin, levofloxacin are the main backbone of a regimen in a drug-resistant TB. So this resistance means it is pre-extensively drug-resistant. Suppose a patient is resistant to this INH, rifampicin plus quinolone, and fourth one, any group A drug. Group A is the top 3 drugs for drug-resistant TB. They are the quinolones, already they are resistant. Otherwise, linezolid and bedaquiline. Suppose it is resistant to linezolid or bedaquiline or both, they are called XDR TB. So we have to go about a long 18 to 20 months regimen with the minimum 4 to 5 drugs in the initially, followed by minimum 3 drugs continuously after bedaquiline 6 months. So like that, if bedaquiline is resistant, you have to go about formulate a good robust regimen with the guidelines. So we can go about the 18 to 20 months. That is XDR TB. Next slide. So we have now come to know about all the definitions. And next slide. So what are the groups of second line? So now you know, because of so much of research and meta-analysis, the drug's efficacy is now being finally taken care of. Not like previous days, we used to, the clinicians with their knowledge used to give a regimen, build up a regimen, reserve regimen. Nowadays, that is not so. We have now meta-analysis have shown how the drugs are being staged or given ranks. So so much meta-analysis, so much study have shown that the top 3 drugs are group A drugs: levo, moxi, bedaquiline, linezolid. These 3 are the group A drugs. They should be incorporated into any regimen. So that is the group A. Then group B, we have 2C, that is clofazimine and cycloserine. Telzidone, we don't have it's not available here. It's a form of cycloserine. So remember 2Cs, clofazimine, cycloserine. These are the next 2 drugs, the top 4 and 5 group B drugs. Then all others are miscellaneous like ethambutol, dilamanate, pyrazinamide, all these. So we have to formulate a regimen comprising of group A, B, then only C if you're not able to isolate. So this is the groups or ranking of the second line TB drugs. Next slide. So though the group A, the ideal regimens will be comprising of group A and B. Here you know the side effects: moxi, QT prolongation. Then we have this photosensitivity, levo, seizures, headache, insomnia, all these things. Then bedaquiline, you know, QT prolongation. Nowadays being used very safely even as a OP drug. So linezolid, very, very notorious drug. It can cause optic neuritis, severe peripheral neuropathy, bone marrow depression. So linezolid, 600 milligram, we are giving. Many times you have to bring it down to 300 because of the toxicity. Then comes the clofazimine. It is a reddish discoloration of the skin, QT prolongation, phototox. Cycloserine, very, very notorious drug. Psychosis, depression, insomnia. Even if you are giving along with the efavirenz, more problems we have seen. So cycloserine is more of a CNS disturbing drug. Then terzidone is not available in India. We have to keep in mind that. Next slide. So what is that we should see now? The main side effects of the miscellaneous drugs also being put. All these are known: amikacin, nephro, autotoxicity, dilamanate, QT prolongation. All these things are there. We also know. And para-aminoetyramide or cause hypothyroidism. So etyramide is being used widely in the shorter MDR regimen. You should know gastritis, it can cause a severe gastritis. So baseline TSH has to be evaluated before you are starting a etyramide regimen. And then PAS has been downsized to as the last drug. PAS nowadays not commonly used. Next slide. So the NTP and NACO has been very much, both have been linked together very nicely, so that we now integrated drug-resistant TB or PMDT guidelines. You can see this is a very populated, like a very crowded slide. Anyhow, I'll just tell you the key points. So whenever you are going to find out through the NAT, CB-NAT or TrueNAT, rifampicin resistance means they are all MDR TB. That they are on the left-hand side. Then you have to only see if they are to be given a shorter MDR regimen or a longer MDR regimen. So we are now talking about the left-hand side diagram treatment algorithm. So remember, you know, RIF resistance, MDR. Now we have to know RIF resistance means you have to know whether we can give a shorter MDR regimen or a all oral longer MDR. Nowadays, slowly the kanamycin is being phased out. So now we are going to give a bedaquiline containing shorter MDR regimen of 9 to 11 months. For that, what are the things you should know? You have to do the LPA, first line and LPA, second line LPA. Suppose the LPA results come out as there are the additional resistances there like pre-XDR, XDR. They are not eligible for a shorter MDR regimen. Same thing, INH resistance, we are going to give shorter high dose INH. So you have to know the breakup of that. INH resistance can be, you should know CATG and INH erased mutation. They will give in the result. Suppose INH-A mutation is there, we cannot use etuanimide. So they are not eligible for a shorter MDR regimen. So we have to go for a longer oral MDR regimen where you should know with the first line LPA, second line LPA results. Also, we are going to give a liquid culture. With that, you can know the exact drug sensitivity resistance pattern. So on the left hand side, we finished. MDR-TB means whether to give a shorter MDR or oral longer. Now shorter MDR also slowly the injection has been phased out. We are going to give 7 drugs in the first 4 to 6 months, followed by 4 drugs in the remaining 5 months. That is the gist of the drug-resistant TB regimen. Then coming to the right-hand side, suppose the patient is RIF sensitive, drug-sensitive TB, you have to give a first line LPA to find out the INH mono resistance. Suppose INH mono resistance is there, we have to give a different regimen, 6 to 9 months of 4 drugs. Suppose it is not there, then you are going to follow the drug sensitivity 4 FDC, then 3 FDC. So this is the important nutshell. These slides convey the meaning. Next slide. So standard DRTB regimens, you know, INH mono means 6 months of levo, rifampicin, EMB, pyrazinamide can be extended for another 3 months. So that is the INH mono regimen or polydrug TB regimen. Then MDR-TB resistance means that is MDR-TB shorter oral. We have 4 to 6 months. Initially 6 months of bedaquiline, but whereas the first 4 months of intensive phase can be extended by another 2 months. We have the levofloxacin, clofazimide, pyrazinamide, EMB, high-dose INH, 600 mg, and etuanimide. Remaining 5 months, we are going to, we will be omitting the bedaquiline, then we will be omitting the etuanimide, and we will be omitting the high-dose INH. Here, remember, usually pyrazinamide is omitted in the drug sensitive, whereas in drug resistance, pyrazinamide is continued throughout instead of etuanimide. So that's you remember. So the three drugs are omitted, and the remaining 5 months is fixed. We are going to use 4 drugs for the remaining. So this is a 9 to 11 months of shorter MDR regimen. So there's a very good success rate is there. One thing is that if any one drug we are not able to use, then they are not becoming eligible. Then we have the shorter injectable regimens there nowadays. You know, kanamycin now is slowly going to be phased out. That is the without bedaquiline, kanamycin containing shorter injectable regimen. This is the 9 to 11 months. Then comes the 18 to 20 longer oral MDR. So what are the things here? These footnotes are showing what are the other things there. It is coming. What suffice to remember that the shorter MDR regimen will be slowly phased out. Injection will be phased out slowly throughout India. That is one point. It is there. And longer oral MDR regimen recommended for MDR who are excluded for shorter oral will be containing the XDR-TB. They will be 18 to 20 months. 18 to 20 months according to there is the given as per the weight band. So these are the important things. Longer oral MDR regimen. You have to monitor the patient for adverse drug reaction. So next slide. So what is that important thing? Exclusion. This slide only tells you anyhow, first you go for a short MDR regimen. How to, suppose it is not eligible, you have to go for all oral. So what are the things you should know? Suppose how to exclusion criteria for short MDR regimen is that H resistance detector, CATG are at both both is there. Fluoroquinolone resistance not detected means they are eligible. Suppose they are detected means they are go for longer oral. Suppose the patient is resistant to some other drug, severe adverse drug reaction to the 7 drugs I told you, the shorter MDR regimen. If one drug is also adverse drug reaction, he has to be put in a longer oral regimen. So this is the important thing you should know. How to exclude, suppose there is a problem, you have to exclude the shorter MDR, go for the all oral. Suppose pregnancy is there, we cannot give etomidate. Severe drug allergy to some drug, say for example, one of the drug like cofazamine, then you have to go for all oral. So this like 7 or all or none. 7 working you have to give, otherwise you have to go for all oral. Next slide. So monitoring the clinically follow-up sputum, so NTP and district. So we are very important that cure, treatment, all this same thing, last to follow it. So important here is that drug to drug and adverse drug reaction. You have to closely monitor, counsel the patient, and you have to see to that they are getting the drugs adherent, and we successfully complete the treatment. So with the newer NTP, the PMDT, now more than 80% cure rate, good. Previously it was very dismal, the drug resistant. Now it is very, the future is looking very rosy for the drug resistant TB patients. Next slide. New drugs have come like bedaquiline, delamide, everything is good. And bedaquiline, delamide are the new drugs which has come. So, these are the new drugs which have come effectively for drug resistant TB. Same thing, clofazamine and the linezolid are revisited drug, or they say revisited drug or repurposed drug. So these 4 drugs are very good drugs. So dolutegravir based regimen can be the choice for the newer drug, bedaquiline. Already on NRTA DDT regimen, the same to be continued, no need to bother. It's on NNRTA PA based regimen, substituted with DTG based. So suppose it's efavirenz or a protease inhibitor, substitute. Then other things, PA based regimen, intensive monitoring is required. No dose adjustments needed when delamide used for efavirenz, lopinavir. Concurrent use of efavirenz may not require dose adjustment. So these are some points they are represented. Next slide. So management of children. So some few points on children. Next slide. So what is the children? We have primary progressive TB. So they have a progressive primary progressive complex, more extrapulmonary TB, lymph nodal TB is more common, pericardial effusion, all these are common. Then multi-drug resistant TB, you have to be very careful because of the contact history. You can find out the multi-drug resistant TB. Close household member having drug resistant TB, higher case fatality. Next slide. So they can have a high case fatality. So what is that? The clinical thing, fever, cough, failure to drive, weight loss more than 5% the body weight when compared to the last 3 months, no weight gain for the past 3 months. History of contact is very important. Then other extrapulmonary like brain TB, bone TB, pleural pericardial effusion, breathlessness, all these you have to, abdominal pain, like abdominal lymphadenopathy or ascites, the things you have to be very careful. Next slide. So these are the things on the, so the diagnostic algorithm, only thing is that other cases like short duration of fever, you have to rule out the other things. Then lymph nodes, you have to very carefully examine the lymph nodes. Chest X-ray becomes very important in a child because they cannot expectorate and give. So less than 3 years, you have to have a gastric aspirate by a pediatrician, 2 samples every day morning, or more than 3 years up to 5 years, the patient can be given a saline nebulization and they can be given induced sputum can be tried. All these are depending on the resources in your setting, you can try these things or get the help of the pediatrician. So these are the same thing, not much of thing. Only thing here, the sputum may be taking a back seat and X-ray and other things like a MAN to other things will be very important. Next slide. And weight band, same thing, 10 milligram per kg, reforms 15. So 10, 15, 20, 35. This is the important thing, drugs in children. Next slide. So weight, accurate dosing is very important. So daily dose schedule for pediatric patients is there. Here, main thing is that you should know ethambutol. Small children, you have to be very careful for the optic neuritis. Next slide. So ART drug regimens for CLH during co-treatment drug sensitive. So these you know better. Already we have discussed abacavir and less than 30 kg, less than like that 20 to 30 kg. Same thing, dolutegravir, same thing. Not much of a change here in the FDC. This is for the children with the CLH with ART TB co-infection. Next slide. And MDR TB algorithm in children, not much of a difference. 21 guidelines. Important thing is that childhood TB, drug sensitive or drug resistance means source is the DRTB patient. Yes. Contact with infectious TB patient is present means source patient is not, source is retreatment or child failing first line treatment, presumptive DRTB. Here we are having a diagnosis of probable DRTB, presumptive DRTB, and go and search for more evidence from the clinically and as well as bacteriologically or lab wise, and see that and consult pediatrician to treat as a probability. So we have the help of the pediatrician, and a collaborative treatment is important, needed for childhood MDR-TB, which is a very difficult thing to diagnose, and you get the help of the pediatric department. Next slide. The guidelines are there. So criteria for probable means, what are the probable MDR-TB in children? Close contact with known case of MDR-TB. Signs of active TB plus these additional: close contact with person who died while on TB treatment, close contact with the person who failed TB treatment, non-response or failure of first-line treatment. These are the important clinical criteria, history-wise criteria for probable MDR. Previous treatment, second-line medication, all these are things. Next slide. So, regimen and duration. The shorter oral drugs, now Delamanid is there, 5 years and above. We are, a lot of things are going on. Operation research for bedaquiline and Delamanid for pediatric cases. And Delamanid is very safe in pediatric, less than 3 years to 5. So we are giving all this in the phased manner. We are stepping up, and so the newer drugs are being used in the pediatrics. So regimen until the complete joint, the stage to implementation oral, shorter oral pediatric regimen, can continue to use injectable regimen. So this is the same thing as an adult. Only thing you have to monitor well. Bedaquiline cannot be used in small children. Next slide. Less than 3 years or 5 years. Protease inhibitors means rifabutin. You have to replace with rifabutin. These are the special situation. TB treatment, PLHA with protease inhibitors. So you have to use rifabutin. Next slide. Already we have discussed this. TB treatment, children with the CLHA with PA means super boosting of flopyridine is recommended. 1:1 double dose. Replace boosted PA with TDG. One the children is, child is more than 6 years of age and with weight band more than 20 weight, then you can give dolutegravir twice daily dose. Next slide. So these are some small adjustments. Pregnant and lactating women. What is the important thing? All the first line drugs of TB are very safe during pregnancy and lactation. Second line things, amikacin streptin not safe. They can cause cranial nerve damage, and use of quinolone in pregnancy can affect cartilage development of fetus. Euthyroid can cause fetal malformation. Bedaquiline and best avoided pregnancy, it's more evidence. So there is an algorithm is there. Less than 20 weeks of pregnancy, how to go about, more than 20 weeks, medical termination of pregnancy, all these MTP are there in the PMDT guidelines. So among the ART, dolutegravir reference containing regimens are safe in pregnant women. However, they can exercise co-opt out for dolutegravir. So these are the important things, are special situations that to pregnant women. Next slide. So renal impairment, already we have discussed that. Next slide. So I think we are running short of time. TB also iris. So important thing is the iris. We should know iris can occur in 1/3 of the patients with TB. So TB is one important thing. Even without HIV, paradoxical reaction we have seen in patients. So in lymph nodal TB, in effusion. So TB iris is very important. Typically presence within 3 months, even within 5 days, we have seen patients coming back with the thing. So we have to only think, know that it's not a drug toxicity. You should not misdiagnose as drug toxicity. First 6 months of ART, any TB case coming, don't think that it's a clinical failure. Then could be a iris unmasking. So you have to be careful. So at times serious reactions, meningeal TB, massive effusion, adenopathy causing tracheal, all these can occur. In that case, you have to use judicious steroids along with the ART ATT. Next slide. So TB associated iris we have discussed. And next slide. What are the prevention? Prevention, there are 3 I's, 3 I's you used to tell junior police. Intensified case finding using 4S complex along with the molecular test. TB preventive therapy, that is INH. Second I is INH preventive therapy. Then third I is air control, infection control. So these 3 are the general preventive principles for prevention of TB in PLHA with various centers, ART centers. So INH is the most effective bactericidal drug. Previously, we were having apprehension. Why use one drug, important drug and waste? Nowadays, we are able to rule out active TB nowadays with good molecular tests. That's why we are boldly using the INH prophylaxis. That too, resistance will not come because the latent TB, then only few bacilli slowly multiplying, so does not promote drug risk. These are the gray areas we were having doubt. Now doubts have been cleared with all case studies and operational research. So INH prophylaxis for 6 months being given, and even we are other things like rifampicin and high-dose INH weekly ones for 12 weeks are in the pipeline, like they are in the undergoing studies. So that can also come. Then we have this levo prophylaxis for MDR-TB contacts. All these are there coming up. Next slide. So these three air infection control, 3 I's already discussed. The first I is intensified case finding, second I is INH prophylaxis, third I is the infection control. So managerial measures in the higher ups, managerial measures are being taken at the country level. Then administrative controls in the ART center, where fast tracking of the patients, where 4S symptoms are there, fast tracking of patients, where separate queue and other things. And the environmental controls, good cross ventilation, all the equipments, gadgets to be put so that to control the infections, like other machines which are being put for eradication of the bacilli and COVID. And the COVID pandemic has given us a good insight into the environmental control. Then personal respiratory protection for the healthcare workers in the form of N95 mask. Even there, the sputum positive patients can be given this surgical mask. There, they can bigger droplet when they cough, it will not be put into the as they will not become a droplet nuclei in the atmosphere. So the patients, sputum positive patients, can be given a surgical mask. The healthcare worker N95 mask. This is a personal respiratory protection. All these 4 are now being totally taken care of because of the COVID pandemic. We now know. So effective implementation of AACE measures, all like the 4 in the hierarchy. Next slide. So these are the things we have discussed. Actually, we're going 5 minutes more. We can have some time for any discussion or anything. Others can also have their experience. They can share any important finding, these HIV-TB, any important case history, anything in the short 5 minutes time we have for discussions. Thank you for your patient listening. Hope I was okay. Thank you.
Thank you so much, sir. Any questions from the participants? Sir, I'll take the questions from the chat box. Yes, meanwhile, please. If anybody wants to unmute their mic and ask questions, please go ahead. So there's one in the chat box. Suppose a person has already finished 6 months of IPT. Later on, he develops TB and completes ATT. Should this person get another course of IPT at the end of ATT?
Sorry, I couldn't.
I'll repeat, sir. A person has already finished 6 months of IPT treatment, and yes, then he develops TB. He completes his ATT treatment. Okay. So should he again be started on IPT after completion of ATT, completion of his TB treatment?
No. I think if once they have completed the ATT, no need to start second time IPT. So no need for that. We have to actively monitor the patient, follow up the patient. One thing I wanted to just an important point I want to tell the audience and junior colleagues that after the ATT 6 months of drug sensitive TB is over, we have to give two weeks the extra of dolutegravir twice daily, because this enzyme deceleration will take 2 weeks. The cytochrome P50, the rifampicin effect will be there for 2 weeks. Slowly it will come down. So another 2 weeks you have to give dolutegravir double dose. Then we can go to single dose. That's an important point I forgot to tell.
So what is the role of IPT in MDR-TB contacts?
MDR contacts, INH prophylaxis will not work. The guidelines says don't use. They're trying this levofloxacin. If quinolone sensitive MDR-TB means pure MDR-TB, not a pre-XDR, they are giving levofloxacin as a chemoprophylaxis for the household contacts. But that does not, I think, come into guidelines. It has been tried in various places. The feedback will come in course of time. That is quinolone prophylaxis, not the INH.
Right. What is the dosage of DTG in MDR-TB treatment?
Yes, MDR-TB, there will not be, rifampicin not going to be used in MDR-TB. So I don't think there will be any change in the dolutegravir plan.
Any more questions from the participants? You can either put them in the chat box or you can unmute your mic. which are the circumstances that IPT should be stopped?
Suppose IPT you are going to give along with the ART, some peripheral neuropathy occurs. Usually the statine or other drugs are not there, even though suppose the patient is an alcoholic or a diabetic and he gets a INH induced this peripheral neuropathy is aggravated or something like that, more what is that? It is incapacitating peripheral neuropathy. We have to stop the INH. Sometimes some INH, this derangement of the liver enzymes is occurring, and INH could be the culprit. So that time you have to stop the INH. Mainly the peripheral neuropathy. Sometimes INH psychosis can come when you're going to give. Sometimes there's odd behavior and something. Very rarely it can come. So we have to stop during the time. You have to stop and never re-challenge.
Dr. Rupeshri has written modified ATT.
Yeah, so the modified AT, now we know the fixed 4-drug combination is being used wide within the guidelines. So we have to go about that. Suppose you cannot formulate the 4 drugs because of severe ADR or some other problem, then we have to go for a modified ATT with the loose drugs. That only will be available in the district TB centers, and you have to send, say for example, 1 year of treatment with SM, INH and levofloxacin, something like that, or some other treatment. We have to send them for a modified treatment regimens. That will not be available routinely in the NTP.
So there are no more questions in the chat box. Can we quickly run the feedback form? The feedback poll is now visible on your screen. Please scroll through all the 4 questions and answer them.
I have feedback form. Yes, sir. Feedback form. Feedback.
Any more questions from the participants? Please feel free to unmute your mic. Thank you so much, Kumar sir, for facilitating this session.
Thank you. Thank you, Sweta. Thank you, everyone, for the patient listening.
Thank you, sir. Thank you, everyone. So we can conclude the session now?
Yes.
Yeah, thank you, sir.